Public health officials are also playing a key role in our efforts to tackle the opioid crisis and limit its impact on seniors. Our next conversation will focus on the work of the Office of Inspector General within the Department of Health and Human Services and what they're doing to uncover fraud, abuse, and misuse of opioids as it pertains to the Medicare program. Please join me in welcoming Gary Cantrell, Deputy Inspector General for Investigations, and Ann Maxwell, Assistant Inspector General for Evaluations. And Bob, back over to you. Welcome. Thanks so much.
Thanks, Johanna. And Gary, thanks for joining us. I first want to get to the report that you put out this summer, startling report. What were the key takeaways from what you found in looking at the data?
Thank you. I think we already heard some of the key takeaways from Congressman Clark, but I think what the data really revealed, the final takeaway, is that Medicare may be paying for opioids that are not medically necessary. And in fact, Medicare may be paying for opioids that are doing harm to seniors and perhaps even others, as those drugs are diverted into the street for resale and then find their way back into homes and communities across the country.
How do you guys work? How does it work with collaboration and your different roles? And Gary, I'll throw it to you and a kind of day-to-day basis.
So this data report is the perfect example of how we work across the OIG, across disciplines, to tackle problems together. So we have national fraud, healthcare fraud takedown this past summer. In anticipation of what we knew was going to be a takedown this year, we were identifying the most concerning issues to us, and in order to shed greater light on the problem and the scope of the problem, besides just talking about the number of people we've arrested or the amount of fraud that occurred, we also wanted to talk about how much of these opioids are potentially being prescribed inappropriately. So we worked very closely with Ann's shop in advance of our takedown, talked through these issues, and really provide context for policymakers, for the public, and put some real meat behind that takedown to talk further about how we can implement change to help avoid some of these problems.
When you talk about the fraud here, I mean, how rampant is it? And can you give me an example of how it gets on the streets and who the bad guys are?
The fraud it's an increasing part of our portfolio of our fraud work. So prescription drug fraud, including opioids, takes up about a quarter of our workload. And over the past several years, opioids have become an increasing part of that. So we partner with the DEA, the FBI, the Department of Justice to really hone in on this particular problem because of the impact to patients. So the fraud schemes that we see often involve physicians who are either receiving kickbacks or have unfortunately been overcome by greed instead of caring for patients and are prescribing pills that are medically unnecessary. These pills often, in many of these cases, lead to overdose deaths, and that's the most unfortunate outcome in some of these cases. In some situations, we have pharmacies that are also involved. There are kickbacks that kind of are the glue that holds these fraud schemes together and connect individuals across the disciplines in this distribution network, creating this problem. And it's not just, this isn't a white-collar fraud problem. This is a true criminal element enters into this business. So we see traditional drug trafficking organizations involved in healthcare fraud because it has become pretty easy to get these prescriptions and get them filled and get them paid for, and including most recently criminal motorcycle gang. So the problem is real. The report that Ann's office put out shows that if there's any question as to why the OIG and HHS is involved in this fight against opioid abuse, the $4 billion Medicare spent on opioids, the 70,000 beneficiaries that are receiving extremely high dosages of opioids that are well beyond, over the course of a 12-month period, they're well beyond what CDC guidelines recommend, and the 400 or so prescribers identified in that report that are contributing to this overprescribing. So their enforcement efforts are driven by data, driven by leads, hotline tips, informants, but this data helps us focus our attention on those that are exhibiting the most risky prescribing practices.
And why did you look at this issue? What's the impetus? And when you looked at the data, was there something in particular that surprised you? And as the third part question, is it how much of the problem is illegal and some of it is legal, where people get addicted?
Sure. We're very concerned about the opioid epidemic, as so many are. So we wanted to, as Gary said, use the data at our disposal to understand the issue more, to understand in particular how the issue was affecting seniors in the Medicare program. And when we looked at that data, we did find some surprising results. As we already talked about, a third of seniors. That's, as Congressman Clark pointed out, that's 14.4 million beneficiaries.
That's per year.
That's per year. And as Gary pointed out, some of them are getting really dosages that can be called just extreme. They're 2.5 times what the CDC recommends that doctors avoid giving patients. So
well, why are they doing that? I mean, is it corruption, or is that they're just not paying attention to the CDC guidelines, or?
We don't know exactly, right, because we just have the data to look at. When we looked at the data, we did look at two different types of populations. So we did identify beneficiaries who appear to be receiving excessive amounts. We don't know why. They could be not getting coordinated care. It could be that they're diverting. We did also look for what were sometimes called doctor shoppers. So those are patients that are not only getting extreme amounts of opioids, but they're also receiving them from 4 or more pharmacies and 4 or more prescribers. In one example, a beneficiary received 46 different prescriptions for opioids, some opioids from 46 different prescribers, from 20 different pharmacies over the course of the year.
Wow. And
in 1 month, it was 11 opioids from 8 different prescribers scattered across 5 different states.
How do you, and is anyone looking for that? I mean, how do you, is it, or the mechanisms not able that the system has a red flag on that kind of situation?
We recommend that there are more red flags put into place. So in the report, we call for a multifaceted approach that starts with physicians. Physicians need the information and the tools in the clinical setting to get a full picture of what the beneficiary's history with opioids are before they write that next script for opioids.
Gary, what has worked in addressing this problem?
I think one of the examples we've seen across the Medicaid program that works is what we call a beneficiary lock-in. And that allows a single prescriber or a single pharmacy to manage the prescriptions for opioids for a patient who has demonstrated to be at risk. And this is something that we have recommended be implemented in the Medicare program, which we think would be it's a critical tool to manage this population that we've identified, the 500,000, or maybe it's the 90,000, that should be more closely scrutinized because of the volume of prescriptions, opioid prescriptions that they're receiving. And Ann's office, again, through their reports, have made these recommendations, and we're excited that Congress has authorized CMS to do this, and we're very interested in its implementation.
And what kind of data did you use? How old was the data, and how reliable was it?
Well, in the Medicare program, we're quite lucky. We have access to data that covers the entire program. So we looked at data from the Medicaid prescription drug program for the entire year of 2016.
Okay, and what next? Will you study the Medicaid population, or what's next on your plate?
Absolutely. We are looking to turn our attention to the Medicaid population. Unfortunately, in the Medicaid program, we do not have access to a data set like that covers the nation. We are still working to achieve timely and reliable data in Medicaid that would allow us to do the sort of sophisticated analytics and pinpointing of our resources that we are now able to do in Medicare.
How do you get that, though? How do you secure that? Who has to sign off on that?
Well, the Centers for Medicare and Medicaid are currently working with the states to aggregate state-level data at a national in a national database. It has been quite challenging, and it's been a number of years in which they are trying, and we continue to push for CMS to work with the states to get complete data, but also reliable data that we can rely on that has the sort of quality that we need to do this sort of work.
Gary, on the fraud element, you touched upon this earlier, but I kind of want you to talk a little more about it, of how you get tips, or how, is it a large percentage on the hotline, or is it referrals from DOJ has found something, kind of that whole world is fascinating.
It really comes in all varieties. So many of our cases are developed, again, because someone on the inside, a whistleblower, comes forward. And that is, we are very much dependent on whistleblowers with that inside information to bring us those leads and provide us, oftentimes, evidence of the potential fraud. But the data, as we've discussed, allows us to put our resources in places where we know there's a greater need because of the volume of the high prescribing, for example. And that's how we formed our national strike force teams in 9 cities across the country, built on analytics and intel from the ground, so that we focus our attention and team up in areas where there's the greatest amount of fraud. And we've done this again most recently in 12 additional districts where we're fighting the opioid crisis specifically. In this past year, 12 districts were identified. This is an effort with Department of Justice, FBI, DEA, OIG. All of our agencies partnered up in these 12 districts to specifically fight the opioid crisis. So we've shifted resources in these districts as well to continue to focus on this effort. So we get these leads from our partner agencies, we get these leads from private citizens, state agencies, other law enforcement, and the data as well.
And as far as your report and looking at, we talked about how big this problem is, opioid addiction among senior citizens, but is there any part of the country that it has the worst part of the problem, or is this something you're seeing urban, rural, across the board?
We do, as Gary noted, identify geographic hotspots, and that's where we will direct our resources disproportionately to address. In the report that we just recently produced, looking at high-risk beneficiaries, there were some states down sort of the southeast that showed a greater opioid utilization than other states in the country.
Is there, and do you know why, in particular, that it's there and not other parts?
We don't at this point. Okay. So the first step is to do the analytics and then turn it over to our investigators or the Centers for Medicare and Medicaid to understand the context. The data only takes you so far. It gives you certain insights, but you really need to go further to understand the full context. Because, of course, when you see extreme amounts of opioids, there could be legitimate medical reasons for that. But it could also be an indicator of fraud. So we need to do those next steps to understand what's behind the data and then determine what the best action is to take to solve the problem.
We are going to open it up for questions in a couple minutes. Gary, as far as what do you think on the ground? Number one, what are you seeing that people in Washington may not know? And number two, and this is really open to both of you, is what can provider groups do more to help?
So I think what we're seeing on the ground is just that up close and personal that this epidemic exists, and that there are unfortunately medical professionals who have decided that greed takes precedence over patient care, as I mentioned before, and are willing to participate in these schemes. So that is the worst part of it. Those that we trust the most are willing, because of a variety of reasons. Maybe they found themselves in some financial difficulty, or just see that the money flowing in much more quickly than it used to. But we've seen too many physicians whose decision-making has been corrupted. And that's the worst part of our job, is when we see that. But the solution, I think it's going to take additional resources on multiple fronts, additional focus at a minimum, not just on enforcement. Clearly that is not the only solution. It is a part of the solution. But one of the alarming trends that we're seeing now that I think we've all heard about in the media is now the individuals who are addicted, who need treatment, are being taken advantage of to further additional fraud schemes. You've heard about probably the sober homes where individuals addicted to opioids are housed. And then it basically becomes a fraud mill, from pill mill to fraud mill, where they're taken to various treatment centers, provided various ancillary services that are either not provided at all or not necessary. And it's just a means for billing both private insurance. It's largely affected private insurance, but has affected Medicaid as well. So we're seeing, unfortunately, the corruption from both the prescribing side, all the way now to the treatment side, and that's an alarming trend.
We will open it up for questions in the audience. There's one in the back there. Again, if you can just identify yourself.
Hi, my name is Laura Warby. I'm a family nurse practitioner, and I am a prescriber of opioids. A couple of things. First, there's one tool that you haven't mentioned, which is the prescription drug monitoring programs, and these are available in all states and the district except Missouri, as far as I know. And that is a very powerful database that we can use when we're sitting in the room with the patient to check and see who else is prescribing, where they're getting their drugs. And at least in the district, our PDMP is relatively new, but they're going to make it available as a data source for researchers disconnected from the individual. So I'm wondering whether you, on the federal level, have access to all of this data across the state, because that's where you can really pick up some of the fraud. The second piece is, when I'm sitting with the patient in pain in front of me, I also need more tools as alternatives to opioids, and that's where perhaps the federal government has a role in expanding access to alternative kinds of treatment that don't necessarily make a lot of money for pharmaceutical companies.
Yeah, I didn't use the actual terminology, prescription drug monitoring program, but that is what I was referring to when I talked about the need for prescribers to have full information in the clinical setting. I was thinking of that tool in particular. So we do recognize the benefit of that tool. Unfortunately, we do not have access to that data. That is a state-based program, and there are various state rules that prohibit the use outside of a clinical setting of that data, especially for the type of data mining that we're talking about here today that allows us to understand where the hotspots are.
And on an enforcement side, we do have access in some states, but as you know, the implementation of those prescription drug monitoring programs varies greatly from state to state, whether that data is required to be entered, required to be checked, whether it's made available to law enforcement. Those are all variables that prevent us, at least, from having access to that across the country.
Another question up front?
Brian Caskey. In some respects, we've seen this before. In the 1980s, there was an epidemic of inappropriate prescribing of antipsychotics to older adults, pretty rampant and pretty brutal. In response to that, Congress passed a bipartisan Nursing Home Reform Act that effectively stopped this, and there was a decade-long reduction in antipsychotic prescribing. Do you think we could use the NHRA as an architecture, maybe amend it or expand on it to help address this issue?
You know, we have done work in that area looking at the overprescribing of antipsychotics in nursing homes, and are pleased to see that that rate is going down. I am not particularly familiar with that piece of legislation exactly, so I'm unable to comment.
I'm Dorothy Stevens. I'm going to follow up with that. Nursing homes are regulated, but assisted living homes are not regulated. And I had a situation with my grandmother where 300 antipsychotic pills were ordered. Obviously, she didn't take them all. But the administrator in the assisted living home had hoarded them under her desk. And I did file a complaint, and I'm a data analyst, so I had all the data written out. And, you know, they closed the case. So it's only as good as the investigation. Now, granted, I was dealing with the town of Greenwich, Connecticut. So, you know, it was kind of hard to, you know, fight the whole town. But, you know, there's a disposal aspect too. What about disposing of the medication? Some states you have to give it back, some states you don't.
Well, we know that in the opioid space, the DEA runs these national take-back programs, and I believe those are extremely effective in collecting unused opioids. And I don't know the statistics, but I am aware that many of these opioid problems begin when folks go into the medicine cabinet at their homes and grab prescriptions that aren't being used, that are just sitting there. And so that's one of the huge areas for diversion that I think has been highlighted. So disposal of unused prescriptions is critical.
have time for one more question.
Stanley Campbell with Eagle Force. We're in the analytics space, and we actually see a large complement of the information, but I'd like to follow up on the PDMP question. No state PDMP allows the individual to get the medications stopped before they leave the pharmacy. The PDMP's been in place since 2006. Most of them in 2008. By the end of 2018, you'll have probably every state with a mandatory PDMP check. So that's 7 to 10 minutes added to the transaction at the pharmacy and the doctor's office. So let's say 15 minutes times 275 million per year. So the workload as it relates to what the ask is from the two congressional folks, if we are able to make the recommendation to them that the transaction actually happened in real time, it actually happened in the pharmacy and the doctor's workflow, as opposed to a person in surgery coming out to go look at a PDMP system because it's their DEA number that's on the line, and then they come back to the surgery. This was not my motion. This was a motion out of the doctor, the head doc in Louisiana. So the question is, does it make sense to catch them before they get out of here, to make the strong recommendation that these things actually happen in the workflow, such that we're not overburdening the doctor, turning the doctors into police? Because even though there are nefarious actors, the doctors really only represent about 1% or less than 1% of the doctors are bad doctors. Less than 1% of the pharmacists are bad pharmacists. It is a person problem. And as a veteran, when we have 10 deaths per day, we've got to do something quickly and not 2020.
Yeah. What do you think?
I've absolutely heard those concerns before, that one of the struggles with the PDMP is that it is not integrated into clinical flow. And that is what challenge for doctors and pharmacists to actually use the data. And so that has to be tackled. As we know, CDC says we're losing 91 people a day. So I think there's a lot of need to really think about these things very carefully and to remember how we can implement them such that they're used in the way that they're intended to protect beneficiaries and save lives.
We've run out of time. Please thank Ann and Gary. Really appreciate it. I'll hand it back to Johanna.